I am joined today by Seema Verma, who is the EVP and General Manager of Oracle Health and Life Sciences, former CMS Administrator. Seema, welcome to the Scale Community Healthcare Podcast. You're the first CMS Administrator I've ever spoken to. I've spoken to and interviewed former heads of Medicare, CMMI, governors, senators, but you are the first administrator of the entire CMS program. So I just got to jump on the opportunities. Global markets and healthcare. My sense is that when it comes to AI adoption, best in class technology, some are going to move much more efficiently than others. And I have a sneaky suspicion which countries will and which won't, and why. Do you view the world from that lens as well? Do you think of countries that have a rich mix of private, for-profit, and public, non-profit healthcare or government-funded healthcare versus governments that are single payer, single employer, and see them differently in terms of rate of adoption? Or where do you stand on that? And I know Oracle is such a global company and to some extent, again, has an advantage bringing best-in-class solutions to the world because you've been global for decades. How do you view the world from a healthcare lens when it comes to adoption of best-in-class products?
Yeah, that's a great question. And what we're seeing across the board is that the demand for these products is very high across the board, right? So whether it's a single payer system, whether it's the NHS, whether it's some of the
Everyone's struggling.
others.
Everyone's short on supply and long on demand.
Right. So everybody's struggling, right? It doesn't matter who's paying for the healthcare. Everybody's trying to figure out ways of being more efficient. So there's great demand. And I think there's also recognition that the old products of the past, products that were built in the 90s are not going to cut it. And so what we're seeing from the international markets is hurry up, hurry up. The other thing that I would say that's sort of interrelated is data sovereignty, right? So a lot of the specifications from governments is that they want to make sure that the data stays in their country. And this is where I think Oracle
That's
has a
interesting.
unique opportunity. We do have our data centers and the ability to deploy OCI in a particular country. And so that's also been very attractive. When governments are buying healthcare products, they're thinking more globally about all of their healthcare needs and all of their data needs. And so they may be deploying OCI in their particular country, and then they also want to do something with us around EHRs. And I think it's more than just electronic health records, right? Oracle still is bringing AI to clinical trials. We have our analytical tools that are helpful for regulators, whether it's public health entities or regulators that are making decisions around drug safety, drug approvals, things like that. So we're able to bring a very comprehensive suite of products to them that are very helpful for the government. But I would say across the board, the demand is high. What we're also seeing is that there are some parts of the world where they're still on paper. And they're going to go right from paper. They're going to kind of skip those, and I would say very manual processes and manual products, and they're going to go straight to the AI products. But across the board, I would say it's universal that everybody sees the value in these types of products and they want it as quickly as possible. I think a lot of them just having to go through all the different government processes, maybe faster or slower, but nobody's saying we don't want this. Everybody's saying, how quickly can you give it to us?
And that's probably true on a state by state basis across the US as well, right? Some will be more reticent, some will be more regulated, more anti, and some will move conversely faster. But at the end of the day, you expect adoption across all states.
I expect and if we're talking, there's different products, right? So for analytical tools versus providers that are buying EHRs, right? So it kind of depends on the buyer. I think really any organization is seeing the value of it. I think right now it's still sort of early days for AI, and there's a lot of whether it's buyers out there that I think are also confused about how do I buy AI? I know this is a good thing. I know it could bring value to my organization. I know it can bring some efficiencies and reduce a lot of my costs. But I think the question is, how do I use this, right? And so some of them are, I'll buy this product and it has AI embedded in it, right? But that's where the platform becomes really important. And so I think we're still in the time frame where people are now figuring out, how do I use and acquire AI tools for my business? And I think that's a deeper, larger conversation that many are going through, and they're trying to figure out that piece because Everyone's saying that they're doing AI, right? But really to get underneath the covers and say, well, how is that AI actually built? Does it make sense, right? Is it going to give me the outcomes that I want? And then again, kind of thinking through the flexibility, right? Maybe it only, do you want to buy 10 different point solutions that are all doing a little bit of AI? And then how are all those AI agents coordinated across your entire operation?
We're definitely in the messy part of baking the cake. That's for sure.
Right.
All right.
Right.
My last question to you, and I couldn't be more grateful for your time today, Seema. I have learned a lot. But my last question is a buffet option for you. So if I listed 4 things that consistently I would call highly dysfunctional in US healthcare that we haven't quite solved yet, or at least are a riddle to me, and maybe you have a better answer for why they exist today than I do, you probably do. I invite you to pick one to speak about. Here are the 4 that occupy my mind at different times. 1, foreign clinical labor. So with every day that passes, the strength and capabilities of virtual care improve. I'll use imaging as an example. We provide imaging with all the broadband and cloud-based capabilities that exist. Images fly across the country. And if radiologists in one state can look at an image taken from another state, from another patient, and provide a quick response, great. Medicare is thrilled. The second that action leaves the country and that radiologist exists in another country, that becomes illegal because Medicare doesn't support foreign clinicians providing foreign care to US citizens or US residents. We have a shortage of supply in healthcare and we have way too much cost. Why not fix that? Why not change the rules on that? If you're eligible, if you're credible, if you're certified and you happen to live in Mexico or in Canada or in pick a country, great. Good luck. Enjoy reading these images and using AI tools to enhance your findings. Second, private equity in healthcare. We've gone through the last 3 years a heightened level of pushback on private equity in healthcare, culminating in Oregon State now banning MSOs, not just private equity, but all MSOs and their ability to majority control a clinical operation. On the administrative side, we weren't even thinking about the clinical side because that's always been restricted across all state lines. So the very concept of the investment class in healthcare is being called into question and actually banned in certain states. Third topic, US public-private relationship. The constant recurring attack on for-profit healthcare as some evil thing. For-profit everywhere else is fine, but for some reason, for-profit in healthcare is malignant and nefarious. And then the fourth one is confusion over pricing. The government tries to inject more transparency into pricing across different sites, and yet I'm not really seeing the price signals, the price transparency, and the market reacting to it yet. Any one of those 4 irritate you as much as I'm irritated that you want to speak
Oh
to,
my goodness.
that you
Okay,
think
well
I've misunderstood?
that's a potpourri of topics. So let me
Yes.
just do what I call a drive-by on all of those topics, right?
Okay.
So let
I
me
didn't
start
expect that.
with
That's more than I bargained
you
for.
said price transparency, private equity, and then the ability for foreign services. Was that 3? I'll do those 3, right?
Yep.
Okay. So look, on price transparency, I still think it's early innings. Look, the amount of data that was out there that was released was so significant that I think it's taken us some time to figure out how to make sense of the data. We are starting to hear early innings around the data being used for better contract negotiations. I think you'll see another round of regulation from CMS to make it easier to be able to consume that data. And so hopefully we'll get to the point where data is in the hands of consumers. So it's early days. I think the government as a price setter is always a little problematic. The government is responsible, or the way that they set these payments is through cost reports, right? Which is an antiquated system that actually rewards, the inefficient over the efficient.
Right.
So, it's very possible that
it doesn't react to demand.
Right.
It reacts to cost.
Yeah. Right. So it's very possible that going forward with price transparency that maybe we start using market data as part of the government's rate setting process, but who knows? In terms of private equity, and investors, I think that at the end of the day, we need to hold providers accountable for cost and quality, right? That's why I'm a big fan of value-based care. And so that when we're making decisions about where to seek care, we have that data on quality and outcomes. And then whether an entity is a for-profit, a not-for-profit, or they're investors or private equity, it shouldn't matter, right? And I get
So
a
you
little
want
worried about
fact-driven outcome.
let's just talk about outcomes, right? And I think that providers need to be held accountable on outcomes, on quality, and on costs. Behind the scenes, in terms of the management structure and the investment, like as long as, and there's a lot of great examples where private equity has invested and they've produced better outcomes and lower costs and higher quality. So I don't think we want to throw the baby out with the bathwater. And the other thing is, when we talk about innovation and moving forward, we need our greatest minds solving healthcare's challenges, and that requires investment. So if we try to stymie investment, we may be holding back the healthcare system for innovation. If we're saying, don't invest here, we don't want this kind of investor. I think we should, like I said, if we're holding people accountable on the outcomes, who's investing, the structure of a for-profit or a not-for-profit should be irrelevant. But that is my personal opinion on that.
You're preaching to the choir. I say again and again, does everyone understand that America is the busiest innovator in healthcare in the world and has been for a long time?
Right.
Okay, so foreign clinical labor. Can we use some of it? I mean, we've got the technology.
Look, those
tools.
Look, I think that, and again, I'm just speaking from more of just explaining some of the Medicare rules. I'm neutral on this issue. I think the way Medicare has set up these rules is to make sure they have an obligation around quality, right? Quality of care. They set quality standards and compliance. And so, I think the concern is that they need to make sure who's providing services are under the rules and requirements of the Medicare program. And they obviously can't control that if that's happening in a different country. So that's just an explanation of the policy. My focus right now is on bringing great technology and trying to fix problems through and with technology, and some of the other policy issues.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.